when we talk about fluids and fluid loss, we really have to talk about water. And water is making up most of the body of humans is water. And in a male, let's say a young, healthy male, is going to be about 60% water. A healthy young female would be about 50% water. And a healthy infant would be more like 75% water. So obviously a big piece of the puzzle. This individual in this image is engaged in a week-long endurance race in the desert. And that's just, in my mind, a crazy way to run a race. See who can run through the desert for a week and not die, but apparently it's a common thing. But he clearly is planning on the idea of needing to regulate water balance in his body. Every hand is full with a water bottle. He's got them hanging off of straps everywhere. He's probably carrying well in excess of 1.5 gallons of water with him. And that's probably just one day's consumption. So this water idea is a really important thing, and the ability to keep it straight. Now, when we talked about kidneys, we talked about their ability to regulate water balance and salt balance of the blood. So the kidneys are the organ that's actually doing all this stuff. Let's say that the total volume of water in a person's body might be, for this discussion, 40 liters, or about 60% of the body weight. So in this case, we're talking about perhaps a healthy young male. And what we're going to find is we're going to find water in 3 places: intracellular fluid and extracellular fluid. Intracellular fluid is going to comprise just a little under half of the total body weight, but more than half of the total body water. So this is the water that's inside cells, intracellular. The other, in the extracellular fluid, will fall in one of 3 categories, or rather one of 2 categories here, 2 of the 3 total, and that is interstitial fluid, so the amount of fluid in between cells, and then plasma. And plasma is going to be the water part of blood, or the liquid part of blood. So overall, that's going to comprise about 60% of total body mass. Within the fluid, there is going to be a number of things dissolved in the fluid. And the first one we want to talk about are electrolytes. And you've heard about electrolytes before, but perhaps you didn't know exactly what you were talking about. So electrolytes are those chemical compounds that completely dissolve in water. They completely dissociate. So salt would be a wonderful example of an electrolyte. And when you put it in water, it will completely dissolve into sodium and chlorine. Non-electrolytes typically do not completely dissolve, or perhaps even dissolve really at all in a solution. Both of those are present in body fluids, but of those 2, electrolytes are more important for our perspective because they have a greater influence on osmotic pressure. When we're talking about osmotic pressure, we're talking about generically the salt content of the blood, or a particular fluid that we're looking at. And it doesn't have to be salt, it can be any of these electrolytes or non-electrolytes. But a electrolyte, because it completely dissolves, has 2 different atoms at least in that solution. So it has a much greater influence on the osmotic concentration. And let's remember this: water always follows salt. I'll say it again: water always follows salt. And that means that wherever salt is, water will go. Wherever salt goes, water will go with it. And this is really important. If you remember from kidneys, if we remove salt from a situation, and that was one of the things that was going on in the kidneys, was removal of salt or addition of salt to the urine, and that would be a way to influence water movement. So if you really want to get rid of a lot of fluid, one way you could do it is dump a fair bit of salt by the kidneys, and that will pull a lot of water with it. This is also why people, when they consume a lot of salt in their diet, tend to retain a lot of water, is because, again, water is simply following the salt wherever it happens to go. If we look at the different electrolytes here, sodium, potassium, calcium, magnesium, bicarbonate, chloride, hydrogen phosphate, and sulfate. And if we look at where they are having their greatest influence on the body fluids. If we look at sodium here, we see that it's in relatively high concentration in blood plasma and in the interstitial fluid, so this fluid between cells, but not so much in the intracellular fluid. So we don't find a whole lot of sodium inside cells, but we do find a fair bit of it outside. If we look at potassium, on the other hand, you don't find very much in the blood, and you don't find very much in the interstitial fluid, but you find a lot of it inside cells. And across the board here, we see the different electrolytes have different influences based on where they're found. When we're talking about fluid, we're really going to talk about three fluid compartments: the intracellular, the interstitial, and the blood plasma compartments. And so when something comes into or goes out of the body, it must move through those compartments. Let's say the lungs here. When you breathe in oxygen in the lungs, that oxygen enters the blood plasma, so it enters the blood plasma compartment. Then, to get from the blood to cells, it must go from the plasma compartment into the interstitial compartment before it can enter the intracellular compartment. So anything going one way or the other must go back and forth between these. The reverse, then, carbon dioxide released from the cells, that was in the intracellular compartment, goes into interstitial fluid, then can be picked up in the blood plasma and returned to the lungs for exhaling from the body. If we look at nutrients or kidney function, again the same thing. Incoming stuff has to go into the plasma, interstitial fluid, intracellular, and then reverse the process with waste product. So there's a lot of movement constantly back and forth between those compartments or between those types of body fluid. Where does your water come from? So let's look at intake of water per day, and we'll start here with beverage consumption. So whatever you drink. And this is where some of you do a really good job with your water intake and some of you not so much, in the form of beverages, and it looks like the amount here is around 1,500 milliliters a day. And this is what we're considering minimums, by the way. Feel free to make your beverage intake more than this. But what your beverage is going to have a big influence on things as well. So we're going to say your 60% of beverages, your 1,500 milliliters, should come from water. Not from soda, not from tea, not from any other kind of beverage, from water. Because those other beverages are going to contain substances that alter urine production. And that then can alter, and in some cases mess up, the water balance of your body. So let's say you plan on drinking at least 1,500 milliliters of water per day. About 30% of that water is going to come from food. So when you're eating food, typically it's not completely dehydrated. So especially if you're eating fruits and vegetables, they're containing a lot of water. But even things like meat, anything with moisture to it contains water. So you're looking at another 750 milliliters intake there. Then there's this very mysterious metabolism, 10%. So where does metabolic water come from? You didn't consume it in food or drink. So what happens is when your body is digesting and metabolizing food, some of the byproduct of those chemical reactions is in fact water. So simply by having a metabolism, your body produces some degree of water. If we look at the output there, the output needs to be a minimum of 1,500 milliliters per day. And we're saying minimum for a healthy scenario. We'll talk about in a minute what you absolutely have to produce, but we'd like to see at least 1,500 mils produced. So that means your liquid intake in beverages should equal your output of urine, roughly. 750 that came in from food, roughly 700 mils is going to be lost in what we call insensible water loss. And insensible water loss is water loss that occurs that is not sensible, so you don't feel it, you don't know that it's happening. And this is primarily when you breathe out, you're actually releasing a fair bit of water vapor. and then what is lost through the skin, so diffusion through the skin. And we're not necessarily talking sweat here, we're just talking about loss of water through the skin in a non-sweat form. That then leaves us with 200 mils that are going to leave us in the form of sweat, and that can vary one day to the next based on environmental conditions and also on how well hydrated you are. Then there's going to be a certain amount lost in feces, and that's necessary. You'll remember from our discussions on digestion that if you want the fecal material to easily exit the body, it must be adequately moist. And so this fecal loss of water goes to hydrating, or allowing fecal material to remain hydrated, maybe we should say, as it exits the body. What is it that helps to regulate our water intake? And a big answer to that is thirst. So the thirst mechanism. The question then becomes, what is it that makes you feel thirsty? And really this is a hypothalamus kind of scenario. So up in the brain, the hypothalamus is monitoring saliva production. And if saliva production goes down, then you'll experience dry mouth. So often when your mouth feels dry, you feel that is thirsty, because that's how your brain interprets reduction in saliva production. The hypothalamus can also monitor the osmolality, or the salt concentration of the blood, and if that gets a little too high or a little too salty, that can also make you feel thirsty. Also, if you have a drop in blood volume, then you'll have a drop in blood pressure. Then the kidneys will enter the equation and start affecting the hypothalamus and telling you that you feel thirsty. So all those things come together to make you feel thirsty. Then you drink. Water then makes the mouth wet, makes the throat wet, and stretches the stomach. That then feeds back to the hypothalamus and says you've consumed water, and here's roughly how much you've consumed. From there, it might then feed back and tell the kidneys to get rid of some, or it might say that's about right. Or if you still feel thirsty, that means the calculations suggest that you aren't really satisfied with the amount of water. So interestingly, once you drink something, in a matter of minutes, you can no longer feel thirsty. But that water is nowhere near being actually in the bloodstream and restoring fluid to the body. It will be hours later when it enters the small intestines and eventually large intestines, where most of that water absorption occurs. But within that few minutes, the stretching and the hydration levels of the mouth, throat, and stomach then feed back to the brain and tell you that's going to do the trick, or that's not really going to do the trick, keep drinking. Obligatory water loss is considered unavoidable water loss. You can't help it, you can't stop it. And insensible, that we talked about earlier with the lungs and with loss through the skin, is a piece of that puzzle, as well as the loss through fecal material is unavoidable. And then there's also a minimum daily sensible water loss of 500 milliliters as urine. And you actually are aware of the voiding of urine from the body. You can sense that, or at least I hope you know when you're urinating. And so you need to have at least 500 mils of that, because the maximum concentration you can make urine, as we learned in the discussion on kidney function, is around a concentration of 1200. And to get rid of the average amount of waste product the body produces per day, you have to make at least 500 milliliters of 1200 concentrate urine. So that's where that number comes from. You need at least 1500. In our example of water lost through urine, we saw that was 1500. So that would be not just the minimum to get rid of waste, but that would also help keep the kidneys flushed out. Another interesting thing that happens is we've said that water is only absorbed into the system hours after you consume it, but within a half hour after consumption of a lot of fluid, if it was more than your body actually needed, the kidneys start getting rid of it. So even before it's in the bloodstream or it's entered the main water fluid compartments of the body has done a calculation that says this is more than we needed. And in that case, what happens is it took about 30 minutes to turn off antidiuretic hormone production and to lower it to a level where the kidneys would then kick in. So that delay occurs not because it took that long for the water to get into the system. Again, it's hours out from getting in the system yet. But it took that long to alter antidiuretic hormone levels and then get the kidneys to kick in. You know about the idea of dehydration, but really what is dehydration? Dehydration technically is labeled or defined as fluid loss. And some common causes of fluid loss could be burns, could be a lot of vomiting or diarrhea, a lot of sweat, a lot of not drinking enough fluid to keep the system balanced. And some of the symptoms that come along with it, you feel like a dry mouth, you might be thirsty, you might have dry and flushed skin. So at this point, perhaps sweating has stopped. And when you stop sweating but you're still hot, that's a sure sign that dehydration has reached a clinically critical point. So technically, dehydration is just losing water without equally replacing it as you go. But when you get to the point where urine output's down and you stop sweating even though you should be, that's an extreme level of dehydration that really is going to start causing some clinical problems if you don't fix it right away. So that's a sure sign you need to drink some more. Some other issues that might come along from dehydration as well is weight loss, because a significant percentage of your body's weight is water. The body might actually experience a fever as a consequence of inadequate blood supply, and mental confusion. So some of you are going to work in medical settings, especially in nursing homes, or when older people come into the hospital, they're acting very confused and mentally not functioning very clearly, perhaps physically combative. A lot of times the solution is to rehydrate them, because it's well known that becoming a certain level of dehydrated causes them to become mentally unstable, and so they're not making sense. So a lot of times if you hook them up to an IV and get them hydrated, then all of a sudden they're making sense again and they seem to recover because it was just an extreme level of dehydration. Here we have an example of dehydration, so let's think about this from the different fluid compartments. The extracellular fluid and the intracellular fluid. So if you have too much loss of water from the extracellular fluid, this is dehydration occurring here, then the extracellular fluid osmotic pressure rises. It's becoming saltier, or it's becoming more concentrated with electrolytes. Remember, water follows salt, so if the extracellular fluid became more salty, that means the intracellular fluid is going to move from inside the cells to outside the cell to balance out the extracellular fluid. And once both fluid compartments are equally salty, then the process will level out. So often some symptoms of dehydration might be shriveling of the skin. And so what's happening there is you've lost extracellular fluid, you've pulled it out of cells trying to compensate, and everything is undersupplied with fluid. So you can see the cells start to shrivel up there, so the entire tissue can start doing that as well. If you have overhydration, so hypotonic, meaning more than you need hydration, you've drank too much, let's say, so the extracellular fluid experiences more water content, which lowers the osmotic pressure. So the amount of salt in it didn't change, but the concentration went down. So now the inside of the cell, the intracellular fluid, is saltier than the extracellular fluid. So if water follows salt, that means water goes from the lower osmotic concentration in the extracellular fluid and enters the lower osmotic concentration in the intracellular fluid. So water moves into the cell, cell swells. If that goes too far, and perhaps you remember the pictures of these back in Anatomy 1, we would have talked about hypertonic, hypotonic, and isotonic solutions. Here we're talking about a hypotonic scenario, water going in. And these cells at this point are going to become quite well inflated, perhaps overinflated, and if you take it too far, they might actually burst. Another scenario here that we mentioned earlier is the idea of edema. And we saw the picture in an earlier lecture of pitting edema. So edema is an unusually large amount of accumulation of fluid in the interstitial space. So in other words, this is an increase in extracellular fluid. Perhaps because extracellular fluid, the osmotic pressure went up, and then that pulled more water into it. So sometimes folks experiencing edema, perhaps that's suggesting that their kidneys aren't flushing salt like they should. And then remember, the sodium was mostly found in the extracellular areas. So if the kidneys would dump some salt from the system, that would pull some water with it. Here are a number of different electrolytes, and I'm not going to go through each one of these, but you're capable of looking at them, and you can see what happens if sodium is too high or too low, and some causes. And some of the consequences or the problems can be quite serious, or maybe not so much. So sodium, potassium, phosphates, and the whole list here, you can just look at those and see what the normal levels or ranges would be, and then what happens with too much or too little. So a good informative read there. Make sure you take a good look at this table. Because sodium in the body and its balance is so important, let's talk briefly about regulation of sodium particularly. Because we're saying water follows salt. If salt goes up one place or down one place, then that affects water balance, and that can really affect functionality of that particular tissue. So there are a couple of hormones that are involved in regulation of sodium, and the most important of those is aldosterone. And aldosterone, if it is in high concentration, triggers the kidneys to reabsorb as much sodium as possible. And that's going to occur in the distal convoluted tubule and in the collecting ducts. So those were the last two steps of kidney filtration. So again, if aldosterone is high, kidneys reabsorb sodium. If aldosterone levels are, and that really means that you're dehydrated and that you need to retain some fluid, so do that. If aldosterone levels are low, that means that you are well hydrated or overhydrated perhaps, and that means that no sodium reabsorption is going to occur in the collecting duct. And that means that if you're dumping a lot of sodium through there, it's going to take a lot of water with it, and that helps the kidneys flush out water as well. Let's talk about some very important stuff here, and this was in your reading assignment, but it's so important we're going to talk about it anyway. And that is this idea that you can have respiratory acidosis or alkalosis, and you can have metabolic acidosis or alkalosis. So in the blood and in the body there are buffers. And the whole point of a buffer is to keep the pH where it needs to be. And if the pH becomes too acidic, the buffer will act like a base and actually absorb hydrogen. If the pH becomes too basic or too alkaline, the buffer will act like an acid and release hydrogen back into the system. And that's hopefully going to keep that particular part of the body the appropriate pH. And there are three different buffering systems, and I'm not going to lecture a lot on these, but they are the bicarbonate system, the phosphate system, and the protein system. And all three of those will be helping to regulate acid levels in the body, so hopefully they don't swing too far either way. So if we're talking about respiratory acidosis, and we can say that respiratory, either one of these, whether it's acidosis or alkalosis, is a breathing thing. Either breathing too fast or breathing too slowly. And in the table here you can see what those causes might be. But respiratory acidosis would be when you're breathing too slowly, and that causes a buildup of carbon dioxide in the blood because you're not dumping it out of the lungs fast enough. The solution is to breathe faster. Now, depending on what the cause was, if it was some sort of impaired lung function like emphysema or cystic fibrosis, that might be a very chronic condition. If it's something like you're just sleepy and being lazy, then speed up your breathing and away you go. Respiratory alkalosis sometimes is referred to as hyperventilation, and what's happening here is you're breathing too quickly. And so you're dumping carbon dioxide out of the system faster than it's being produced, and you're increasing the pH of the body significantly that way. The solution here is to slow down the breathing. And one way that that is achieved is by the old idea of breathing in a paper bag. So that's doing two things. One is it's allowing you to focus on breathing in the bag rather than whatever it was, the anxiety, the pain, the whatever, that triggered the high-rated breathing. So focus on the breathing and the bag inflates and deflates. So that helps you to slow down breathing without having to think about it too much. The other effect, really the significant effect that's happening here, is that when you're breathing back in, what you breathed into the bag was a great deal of carbon dioxide. Then when you breathe that high concentration of carbon dioxide back into the lungs, that loads that CO2 back into the blood and then gets your pH of your body back towards the acidic condition that it needed to be. So speed up the breathing to deal with respiratory acidosis, slow down the breathing to deal with respiratory alkalosis. The other side of acid balance is metabolic. And so we can have metabolic acidosis and metabolic alkalosis. So this means that it's some sort of metabolic condition that's leading to this. So something not related necessarily to breathing. And in metabolic acidosis, then whatever is happening is causing the body to become acidic. It might be severe diarrhea, because a lot of those buffering systems are present in the digestive system, and diarrhea could flush that out. It might be kidney problems, might be diabetes, or it might be starvation. So I think I've mentioned this a couple of times, but the keto diet is to some degree a starvation diet. So that's going to cause metabolic acidosis. Metabolic alkalosis would be when some metabolic thing causes excessive loss of acid. In this case, a lot of vomiting, or if your stomach had to be pumped because you put some things in there that were not good. If you overuse diuretics, that can cause a problem. If you consume too much antacid, that could cause a problem as well. Or if you have a problem with the adrenal gland, it might have too much aldosterone, which can then muck up the system with regulation of sodium. So that in that case would cause losing acid. A solution for metabolic acidosis perhaps might be stop the diarrhea, stop the starvation, maybe take some antacids, and that would help to knock out some of the stomach acid, which would then suck acid out of the rest of the body. If you got alkalosis kinds of problems, so you're becoming too alkaline, maybe you need to obviously stop the vomiting or stop the diuretic or the antacid. And you might also look at consuming something like drink a bottle of Coke. And it's going to be very acidic with the carbonic acid, the carbonation, and that will help to level out that metabolic alkalosis. An interesting concept on top of this as well is that you don't necessarily have to treat a metabolic acid problem with a metabolic approach, or you don't necessarily have to treat a respiratory acid regulation problem with a respiratory approach. So if you have, let's say, respiratory acidosis, so you're not breathing fast enough to get rid of the CO2, something that you might do is take an antacid. And that will cancel out the stomach acid. The stomach will then pull some of that CO2 out of the blood to make more stomach acid, and you could level it out perhaps that way. Or if you have, let's say, metabolic acidosis, breathe faster, hyperventilate, and that will dump CO2 out from the blood that way, and then the blood will suck acid out from the rest of the body to replenish the blood supply. So the point here is there are some not necessarily textbook solutions. Obviously, the textbook solution is to undo it metabolically if it's a metabolic thing, or undo it with respiration if it's a respiration thing. But just understand that doing the opposite in any approach will help to deal with that. So you can do a metabolic trick to deal with a respiratory problem. You can do a respiratory trick to deal with a metabolic problem. That would be sort of a quick and dirty, in the trenches kind of solution, when perhaps that's what's most available to you and something else might not be so much. Now, what happens if we have too much acidosis or too much alkalosis, and really, why do we care about this? And that is that you can only live within a certain pH range. So between 6.8 and 7.8 for blood pH levels is about your life range. Anything above or below that will cause a problem. So if you experience too much acidosis, the central nervous system starts to shut down. You enter a coma, and then once the brain turns all the way off, you die. If the pH goes too high, so it becomes too alkaline, the central nervous system is overstimulated. That can lead to uncontrolled muscle contractions, convulsions, and perhaps respiratory arrest. So the diaphragm and the intercostal muscles might sort of convulse and then maybe even lock up, and then that would cause you to die because you weren't breathing. So some serious consequences to that. And I believe I mentioned in a previous discussion as well, I think with lungs, but I'll do it again here, and that is if someone is on oxygen. So they're chronically experiencing low oxygen levels. Perhaps that's some sort of lung problem. So that's going to be a respiratory problem, and probably a respiratory acidosis kind of scenario, because you're not dumping enough CO2 out because your breathing rate's down. And if they experience, or they tell you that they're short of breath and they ask you to turn up their oxygen, don't do it. Because the brain normally monitors CO2 levels to tell you when you need to breathe again and whether you need to speed up or slow down your breathing. But if in that chronic respiratory acidosis state, the brain says, you know, CO2 levels are always high, so that's not really telling me anything, and it switches over to monitoring oxygen levels. And that sounds like it's okay, but what happens when they're on oxygen is they're getting a greater level of oxygen concentration in the blood, and if you turn up their oxygen levels, the brain says, O2 just went up, so we don't have to breathe as much. And from an oxygen perspective, that's fine. But the problem is, if you slow down breathing any more, and you were already in respiratory acidosis, you just made it that much worse. And we've already said here that if the pH goes too low, you get coma and death by the central nervous system turning off. So actually turning up their oxygen might turn off the brain and kill them. So again, if they complain of that sort of thing, don't turn up their oxygen, but pretend to turn up their oxygen, and then ask them immediately, do you feel better? And if they say, oh yes, I can breathe so much better now, even though you didn't do a thing, that's proof that it was a psychological condition. The same sort of idea as if they're complaining of being cold or hot, you pretend to adjust the thermostat, or even if you do adjust the thermostat, but they immediately express that they feel better when nothing has happened yet, then you know it was a psychological problem. If they still complain of being short of breath, then it might not be a psychological problem, it might be a real problem. At which point you talk to the doctor, and the doctor will then tell you what to do. And they will hopefully keep in mind this idea of respiratory acidosis getting worse if you turn up the oxygen. So if they do tell you to turn it up, it's going to be a very small amount that you turn it up. So you want to get it just enough that it satisfies their oxygen needs without additionally depressing respiration rates. And if the number seems like very much of a change at all, ask the doctor about respiratory acidosis, and is this going to make it worse? Because even the best of doctors occasionally forget and make bad judgments. And always with everything you do, make sure you chart it very well, so it's in the written record who said what, when, where, and why, and what you did. So if something does go wrong, you'll be covered that way. So these sorts of things didn't seem like that big a deal, but they can really be that big a deal. And I guess we'll close with this statement, and remember this, we've said it before, Water follows salt. So wherever salt goes, water goes. Thanks for joining us. Have a good day. See you next time.